Thanks very much for coming this morning. It's a great thrill to have so many colleagues and friends and guests here with us. Firstly, I'd like to acknowledge the traditional owners of the land on which we gather and meet and pay respect to elders past and present. The Honourable Dr. Anthony Lynham, MP, Minister for State Development and Minister for Natural Resources and Mines, Professor Alistair McEwen, Acting Pro-Vice-Chancellor Research, staff from Cre Reduce, representatives from government and industry, distinguished guests, ladies and gentlemen. So we're very grateful to have so many special friends and collaborators with us today. This CRE provides an excellent opportunity for some very important research, education, training and improvements to the way healthcare is delivered, particularly for those patients that have severe infections. We're very grateful in particular for the presence of Dr. Lynham, who joins us on a very busy day. In fact, after this he has to take a flight, but we're very grateful for his support and being able to be here this morning. So the reason that we're here is for the launch of our new Centre of Research Excellence, which is called Cre Reduce, so the Centre for Redefining Antimicrobial Use to Reduce Resistance. The structure of today will be in the morning, it's going to be the formal launch, which is what this session is, and this will be include the opening from Dr. Lynham. And there'll be some other presentations related to the motivation for this CRE, as well as the scope of what this CRE intends to cover throughout the 5-year course of it. In the afternoon then, we will have an academic session whereby there'll be a series of other presentations which describe some of the research themes within the CRE and also addressing some of the questions of the scope of what we aim to cover in that 5-year period as well. So the motivation for Cre Reduce really does stem from the fact that healthcare has significantly evolved over recent decades. We now have patients with higher levels of sickness severity than had previously been encountered in the healthcare system. We subject these patients to greater levels of immunosuppression, more invasive procedures, and with this there is a greater risk for them to develop infections. And certainly we're seeing infections on a more common basis these days, and that includes severe infections. Now, severe infections in particular are perhaps an understated problem, and they cause more deaths than road traffic accidents, in fact by a factor of 3-fold greater in Australia. And so the depth of this issue is something which is particularly troubling. And if we take into account as well the fact that it's been forecasted that by the year 2050 that deaths caused by resistant infections, so particularly superbugs, are going to exceed deaths that are caused by cancer at that time. It shows that the trajectory that we're on with this emerging antimicrobial resistance is particularly problematic. And we certainly need to be looking at developing new interventions to overcome this increasing problem for the healthcare system. So what can we do about superbugs? Well, of course, the obvious answer for us is to develop new antimicrobials that have novel mechanisms of action for which they will work effectively against superbugs. And as you can see from this graphic here, that this is a problematic issue in its own right. So on this axis here, you can see the total number of new antibiotics for different 5-year periods over the last 30 years. And you can see a steady decline in this. So whilst there has been rightly investment in developing new antibiotics, and we've got some excellent groups such as the Cooper Group at the Institute for Molecular Bioscience here at UQ that are developing new molecules which have very good microbiological activity. The time to progress that from a molecule which is active to being a drug which can be used for patients can be quite prolonged, as much as 13 years. And of course, there's not necessarily that certainty that once we have that molecule, that we can then progress through what's called the valley of death to try and take a molecule and take it into a formulation which can be used for patients. And so developing new antibiotics is a very important undertaking, but isn't one which necessarily comes with guaranteed immediate effects. Infection control, of course, is something which is very important as well, and this should always be a core part of minimising the effect of superbugs to stop transmission from one patient to another, and certainly ongoing investment in this is an important activity. But what we can do at the moment is we can ensure that we're using our existing antibiotics better than we have in the past. And certainly there's a really strong body of data now which describes that if we can optimise dosing of these antibiotics, then not only are we going to increase patient survival, but we can also slow the development and emergence of these superbugs. So this is what the whole core of what Cre Reduce is doing. We're going to provide a systematic program of research which identifies better dosing regimens for our most severely ill patients to ensure that not only are they going to have better outcomes, but also so that we're going to slow the emergence of resistant superbugs so that we have time for these new antimicrobials to be developed. So this is the schematic which describes exactly what the undertakings within the CRE will be. The first aim will be to use a laboratory-based approach to describe what concentrations of antibiotics are required to stop the emergence of resistant superbugs. We'll have a series of drug dosing studies to describe how drug concentrations change in different patient populations, because it's been very well described that drug concentrations don't behave the same in different patient populations. And then we can combine the data from both of these two aims to then describe new dosing regimens which achieve these concentrations which have been shown in our in vitro models to be appropriate for suppressing the emergence of resistance. We can then test those in some clinical outcome studies, and then once we've identified what those best dosing regimens are, then we can translate those dosing regimens into treatment guidelines, both at an NHMRC level as well as those that are endorsed by professional societies. So if I could give you an example of some of the projects that will be undertaken within the CRE. I've mentioned previously about these in vitro infection models, and these will be predominantly conducted at the Centre for Translational Anti-Infective Pharmacodynamics, which is a new centre which is supported by the School of Pharmacy and the HABS faculty at the University of Queensland. But we'll also be doing work with Monash University, who are very strong collaborators of ours in this regard. We have a series of drug dosing studies which will also be undertaken, looking at a multinational study, looking at better ways to dose antibiotics in pneumonia, which is very important because in critically ill patients, those in the intensive care unit, pneumonia is the most common infection and has a very high attributable mortality rate. We have multinational studies being done in patients receiving renal replacement therapy or dialysis, as well as patients receiving extracorporeal membrane oxygenation or ECMO. We have another series of studies which are being done in patients post-transplant, either lung transplant or heart transplant, liver as well as bone marrow transplant, and these are studies being done in Melbourne, Brisbane and South Australia and Adelaide. We'll be looking at better ways to dose critically ill paediatric patients as well, and these tend to be an understudied group, and we have research ongoing in South Africa as well as planned for the Lady Salento Hospital. Studies looking at better dosing for obese patients. This is something which is very important because of the increasing number of obese patients that we have in society generally, and dosing guidelines typically don't cover for the scenarios which they have. We have one of our PhD students is looking at better ways to dose Indigenous critically ill patients, and one of our PhD students, Danny Sy, is going to speak on that later this afternoon. And then we have our series of clinical outcome studies, including a very large 7,000 patient study done in multiple countries throughout the world, looking at the effect of continuous infusion of antibiotics, particularly beta-lactam antibiotics, and the effect that that has on improving outcomes for patients with severe sepsis, so very, very severely ill patients. Throughout the whole process, something which is very important to us is ensuring that we've got engagement with consumers or patients, as well as the end users of these guidelines. Certainly from a consumer and patient perspective, we're very grateful to have Daryl O'Callaghan, who's our consumer representative on the CRE. He'll be speaking to us later today about his patient journey, and you can see that this is something which is very important to us to make sure that we do deal with this situation effectively. To give you a bit of an idea of the scope of the collaborators that we have within our CRE, you can see on here that we've got lots of different centres around the world which are collaborating with us on the various projects which we're undertaking, over 20 countries, and we're very proud of being able to have that level of activity across the world because it helps with the generalisability of our results. In terms of what the outputs of this CRE will be, A lot of these are based on what the NHMRC, which is the major funding body supporting this centre, what they dictate is something which is very important to come from these centres. So developing new knowledge, so understanding specifically what are those concentrations of antibiotics that we should be aiming for in patients to stop the emergence of these superbugs which are causing such a broad problem for the healthcare system as well as for the wider community. And then once we have this knowledge, then to develop these antibiotic doses which are going to save more lives as well. Capacity building is another very important part of this centre. So training the next generation of researchers and the next generation of clinicians as well. We'll train more than 15 PhD students, a whole series of postdoctoral fellows as well as research assistants. We'll be providing direct education to over 1,000 healthcare professionals. Online training courses will be run by collaborators from the Chinese University of Hong Kong. Professor Gavin Joint is one of the chief investigators on this centre, who is going to be taking care of that aspect of the centre, and he has a broad experience with that. And we'll be conducting a series of advanced workshops, teaching people how to analyse this data better, but also to, once they've got that data, then at the bedside for individual patients, work out specifically what dose is best for them to increase their likelihood of survival as well as suppress the emergence of superbugs. Treatment guidelines are a very important outcome, as well as improved community engagement, as I mentioned before. So I'll conclude there and acknowledge the participants of the studies that have been conducted to date, as well as those that will be present in the future. I'll thank the clinical staff at each of the different sites, because without them, these studies can't occur and they won't be the success that they are. And of course, I acknowledge the CRE team and of course, all our collaborators that are with us here today. So I'll conclude there.